Good morning, good afternoon. Everyone is welcome to this conversation. Thank you for joining us for the National Hispanic Medical Association's Research It, Women's and Girls HIV/AIDS Care in the Gulf Coast webinar. I am Mariana Montero, founder and executive director of Golden Change Inc., a nonprofit organization in the greatest of New Orleans area, with a mission to empower the ethnically diverse community by providing the necessary tools to prevent violence and yield positive behavioral change through improving the quality of life for individuals and families. I am happy to be serving as a moderator for today's event. The National Hispanic Medical Association, NHMA, is a nonprofit association representing the interests of nearly 50,000 licensed Hispanic physicians across the United States. NHMA's mission is to empower the Hispanic physician to lead efforts to improve the health of Hispanics and other underserved population. In collaboration with Hispanic State Medical Association, residents, medical students, and other public and private sector partners, today we are joined by Dr. Julia Garcia Diaz, Medical Director, Clinical Research Group and Pharmacovigilance, PPD, and Dr. Josh Matacotta, Assistant Dean of Assessment Strategies Initiative and Assistant Professor in the College of Health Science at the Western University of Health Science to have a robust discussion on the importance of increasing diversity in generic research to help support HIV researchers and healthcare workers to provide care, increase adherence to promote prevention strategies to vulnerable population. NHMA has partnered with the Center for Disease Control and Prevention, CDC. Let's Stop HIV Together campaign to maximize the effectiveness and reach of the Together campaign by strategically disseminating culturally appropriate HIV sources to the Hispanic community. All of us, supported by NIH, is working with community partners like NHMA to educate Latinos about the programs and how research has the potential to benefit future generations. We hope that our conversation today can address the challenges in which people with HIV experience, as well as highlight the importance of tailored HIV care and treatment services among our community. A few housekeeping I will let you know. One is all participant microphones will be muted, but please feel free to type your questions into the Q&A box for the panelists to address it during our Q&A session at the end. Recording will be housed on the NHMAMD.org and sent out 1 week after the event. Our first panelist is Dr. Julia Garcia Diaz, a prolific researcher who is active internationally in the field of infectious diseases, a certified CPI, and is currently overseeing clinical trial in the field of infectious diseases to include COVID, therapeutic and prevention intervention, HIV and transplantation. She is a fellow of the Infectious Diseases Society of American and the American College of Physicians. Following Dr. Julia Garcia Diaz is Dr. Josh Matacotta, a clinical psychologist with an emphasis on behavioral medicine and health psychology. He has worked in community mental health, university students health center, hospitals, and public schools. Dr. Matacotta served as a scientific reviewer of the NIH, SBIR, STTR, social and community influence across the life course. Review branch of the Division of AIDS, Behavioral and Population Science. Now we have the pleasure to have with us Dr. Julia Garcia Diaz. Thank you and welcome, Dr. Garcia Diaz.
Thank you. Thank you for having me. Over the next 3 minutes, we'll talk about women and HIV. And so for that objective is next slide so that we can sort of look at the objectives of this talk. First, we'll go over the epidemiology of HIV in women and the Hispanic community, and I'll give you some data over the last 2 to 3 years to see where we are. We'll discuss the stigma that HIV poses on the Hispanic community, as well as some of the risk factors that are associated with such, the gender disparities of HIV and AIDS care, and what are the interventions that we can do to decrease the number of women with HIV. We'll talk a little bit about why research as Dr. Matacotta will sort of expand on that. And we'll talk about some of the importance of the cultural competency among the providers that are caring for our Latino community. And we'll also talk about treatment and care of where we are and what are some of the best strategies that we can put in place moving forward. Next slide. So to start, I'll give you sort of an overview globally where we are with HIV. In 2021, there were 1.5 million newly infected people with HIV for a total of about 40 million people across the globe, people living with HIV. And of those, we obviously are still having people dying from AIDS-related illnesses. And in 2021, there were 650,000 reported. Next slide. Next slide. So this is globally where we are in terms of HIV. And if you remember that date that I just gave you a minute ago, 38.4 million people, of those 20.2 million girls and women live with HIV. So if you do the numbers, that's more than half of that number of people living with HIV. As we look across the globe, we can see that the larger the diameter of the circle is the largest of the number of people with HIV. If you look in the center, you see there is USA compared to some of the other countries in Western and Central Europe. To the left, we see Latin America, with Brazil being the most effective. At the top, you see India and Thailand with the highest, some of the highest numbers. Below, you see South Africa and Nigeria. Next slide. As we come back here to the US, and we're going to come back to this in a couple of slides to see what is the disparities in terms of those of those groups that are affected. So if you see here, if we go from the far right, we see that 8,600 affected with HIV are white. Then Hispanics, and then Blacks. And so we're going to come back to these numbers and compare them. How is this compared to what are the distribution of those numbers in the population, in the US population, and how the disparities are found within those. Next slide. So HIV in women, to give you some perspective of where we are, 1.1 million people live with HIV in the US. Of those, almost 25% are women, 258,000. Of those, about 20% that we see here are new diagnosis. So almost 20% are also women. And then if you see of those, almost 20% are Hispanics. So we can see that Hispanic Americans account for almost 30% of all HIV infections that were reported. This data is from 2019. We also can see that Hispanic women are 4 times as likely to have AIDS in that same year when compared to white women. And they're certainly 3 times as likely more to die from HIV infections compared to white women. And we'll talk about some of the issues that are responsible for those numbers. Next slide. So this is sort of alludes to the same of a couple of slides ago, where we see that HIV diagnosis among women and girls, you see 58% in Blacks, and only 21% in whites, and then you see 17%, and sometimes you see that number as high as 20%. By comparison, if you look at the female population, there is a huge disparity in terms of the distribution of the those percentages across. 60% are white, 16% Latinas, 13% Black. So you can see how those numbers are so diverging in terms of the distribution in our populations. Next slide. Now, when we come to the Gulf Coast, we see the diagnosis of HIV infection among females. This is data from 2018, and this is by regions. So you can see the Northeast, Midwest, South, and West. And you can see the purple bar is African Americans. You see that sort of greenish is Hispanics, and then the orange. And you can see that African Americans are almost 25 and higher, as we see in terms of diagnosis per 100,000 population, followed by Hispanics and so whites. If you look at the far right, we see the distribution in the map, and as you can see that the purple, the darker purple, are those that have the highest rates, and you can see that this is in the Gulf South, with Louisiana being 12.8%. Per 12.8 per 100,000, pardon me, and Georgia 12.5, and Florida 10.4, and those rates are very high. And some of our cities here in Louisiana are usually in the top 5 of those that are affected. So very high rates, and we, despite all of the interventions, we are having some, we are not making that big of an impact. Next slide. So what are the challenges for women? What do they face? So women face multiple challenges, and they have to do with a lot of the socioeconomic and structural barriers that they're facing. We see poverty, cultural inequities, partner violence. In addition of that, women certainly tend to put the needs of their families above their own in their household. Additional factors and knowledge of their HIV status. If you see below, for people living with HIV, 90 of those know their HIV status. And if you go to the far right, you can see that only in the Hispanic population, 84 are aware of their HIV status. So by not knowing that, it certainly allows for disease progression, it allows for transmission. So there are a number of factors that being aware of that is certainly affected by. They may not know their sex partner's risk factors. We'll come back to this again, but their knowledge of pre-exposure prophylaxis, which has been around for many years now, and we know how efficacious it is in HIV prevention, many of them are either unaware that it exists, or they're not being offered prescriptions for pre-exposure prophylaxis. They're also at risk for other sexually transmitted diseases. The Gulf South has some of the highest rates in syphilis, chlamydia, and gonorrhea, and and mental health and access to mental health care services as well. Next slide. Challenges that are specific to the Hispanic community when it comes to HIV, we're back to poverty, racial discrimination, lack of access to health care. Language barriers is very important for us to address this population and have bilingual healthcare resources available to communicate with our population effectively and be able to have that in place. So language barriers is very important. Immigration status and all of the goals and all the misconceptions that goes along with that. And certainly there is a great deal of mistrust of the healthcare system as well. So how can we improve that? We need effective health education, but a lot of the health education needs to be able to be in their language. It's be able to have bilingual health resources to be able to communicate that message, that it would help us and end the transmission of HIV here. Next slide. So prevention. So, and this is, we mentioned it a minute earlier, the HIV prevention opportunities are certainly not reaching those women effectively. We know that pre-exposure prophylaxis is highly effective, and it's been around for quite a few years. So if you look at the data that is here, for women, data from 2019, only 10% of women who could benefit from pre-exposure prophylaxis were prescribed PrEP. And if you look in the Hispanic community, only 14% of those that could benefit were prescribed pre-exposure prophylaxis in 2019. Those numbers are dismal. And then there is no follow-up when we look at pre-exposure prophylaxis. If they do get a prescription dose, this does not take into account those prescriptions that are given and how many actually do stay on that PrEP for the long term. Next slide. So the HIV stigma in Hispanics, it's higher among Hispanic women than Hispanic men, not to minimize the effect on Hispanic men. And certainly there is a concern about disclosure of HIV status. I had a patient who was very involved in the Catholic Church. And so he delayed getting tested for HIV. He knew that he had been exposed, but he was concerned that he was positive and did not want to get tested. Once he got tested, did not want to disclose it because of what he perceived would be the stigma that would be put upon him by all his fellow churchgoers. And so it's very hard for patients to be able to disclose their status and be able to get the appropriate health care. There is healthcare discrimination. Sometimes we don't listen as well as we should. And this goes back, not just listening, but being able to speak the language. They may not be able to communicate the message to us, and us being able to address those concerns. Next slide. So how can we address it? And this needs to be a multi-resources to be able to address the efforts to reduce the HIV stigma and discrimination that affects our Hispanic communities. It has to be sort of a well-rounded approach to be able to reduce it in our communities. What do we do? Behavioral interventions that are tailored. Our populations are very diverse. They are not the same. Hispanics from the Caribbean are not the same from Central America, and certainly not the same from South America. We have different beliefs, different cultural beliefs, and our communities are not the same, and how do we address them appropriately? in an effective manner? How do we engage those community leaders? In the example that I just gave you a minute earlier, we engaged the priest at the church, and he was able to sort of talk to the patient, and he was able to feel more comfortable. So he saw the priest at the church as a leader. So there's lots of leaders. It's not just someone, it's sort of empowered, someone who you trust and respect. And so how do we do that effectively in all our communities? Next slide. So HIV treatment and care, and there's a number of layers to this. So how do we address appropriate treatment? So we talk about viral suppression. So we look at patients that are virally suppressed. So if you look at here at those numbers, women who are diagnosed with HIV, you see 76 receive some care, 56% retain care, and then you see only about 64 are virally suppressed, which is a very disturbing number. If you look at Hispanics, the numbers are almost identical in terms of how many receive care, how many are retained care, and how many are virally suppressed, which is certainly much lower than their comparators. We also talked a little bit earlier about HIV status and how many of women living with HIV know their status, and those that do come to testing late in their disease after acquiring HIV and being positive for some time, which certainly leads to complications and transmission as well. Next slide. So in order to improve this, it has to be sort of a whole approach. How do we scale up HIV testing? And we need to bring testing to the communities. We need to be able to have HIV prevention in the community, be able to have that. And the numbers that you see there, it just emphasizes the earlier slide that I showed you in terms of Hispanics being at 16% of being over PrEP compared to whites, which are about 65%. And you can see where we are and the disparities of how prevention is it's being offered. And we need to come to our communities to be able to do that and be able to sort of explain that and having to understand the implications of such. Next slide. So there are certain dynamics, gender dynamics in our Hispanic communities that certainly we need to be aware of. And this is just one example in terms of contraceptive methods. Latinas are less likely to use condom use than their counterparts in white and African Americans. And this is likely due to cultural gender role constraints, female modesty, male dominance in sexual behavior, or any of those misconceptions. How do we educate in condom use? It certainly can prevent HIV, although it's not 100% effective, but it can certainly prevent other sexually transmitted diseases. And so we need to be able to understand some of the dynamics that we see in our Hispanic communities to be able to counsel them. Next slide. So in order to have appropriate interventions that are culturally appropriate, innovation is key. How do we do a total person approach to integrate HIV prevention and treatment into these communities? How do we do that? So it's not just diagnosing, but how do we sort of have effective linkage to care, retention strategies? What about substance abuse? I mean, we could certainly spend an entire hour talking about substance abuse in itself. How do we coordinate interventions at the community level, educational talks that are appropriate for our audience, social network testing, campaigns to decrease HIV stigma? How do we improve HIV testing, treatment, prevention, all of that? And so we need to be able to bring all of the services to the communities with the appropriate cultural interventions. I mean, we need to be able to know what audiences to be able to deliver those interventions. Next slide. So what are the benefits of research? And this is sort of a transition into Dr. Matacotta. We will expand on this. If you see at the right hand, clinical trial participants that are Latinos is only about 10%, very low, very distrustful of the healthcare system. So we know that HIV care research has allowed people to live healthy. They have access to a lot of the things that clinical trials bring. We know that research has contributed to prevention, diagnosis, and treatment of many of the health conditions such as hepatitis C, cardiovascular diseases, and so on and so forth. I've been doing research for almost 30 years, and when we had the COVID vaccine trials, it was very difficult to get the Latino community to participate. So in order to do that, we went to the churches, we went to their communities. We couldn't just wait for them to come to us. We needed to go to them and be able to explain what the research was and what it was about, and be able to sort of explain that, and we can't just wait for them to come to us. So why do Latinos join clinical trials? Lack of information, and lack of information certainly in their specific language. We translated everything in Spanish for our communities for them to be able to understand. There's disparities in access to healthcare, not being fluent in English, so be able to have it in their language. Cultural fears, such as fear of being a guinea pig. They're going to be experimenting on this, so we'll be able to sort of relay our message and be able to improve those numbers. So I'm going to stop there. And thank you. And we'll have questions. And Dr. Matacotta, I'll hand it over to you.
Thank you. That was excellent. Yes, my name is Dr. Josh Matacotta. I am a researcher ambassador for the NIH All of Us Research Program. I have no research funding or conflicts of interest to disclose. The All of Us Research Program is part of the National Institutes of Health. Next slide, please. The All of Us Research Program is inviting 1 million people or more across the US to help build one of the most diverse health databases in history. We are welcoming participants from all backgrounds. Researchers will be able to use the data to learn how our biology, our lifestyle, and our environments affect our health. This may one day help researchers, healthcare providers find ways to treat and prevent disease. The mission is to accelerate health research and medical breakthroughs, enable individualized prevention, treatment, and care for all of us, which is why it's so important to have a diverse number of participants. The AOU program will provide a rich set of health data previously unavailable to scientists. And there are several community engagement partners in the communities that are doing the work out in the communities, talking with people, trying to enroll 1 million or more participants in this longitudinal research cohort. I believe AOU may improve our ability to prevent and treat disease in a way that takes into account our very individual differences in lifestyle, environment, and biological makeup, including genetics. The program is not disease specific. It is focused not only on improving treatments, but also identifying preventive strategies. And it is because of our partners, the participants, that all of us makes it possible for diverse communities to be represented in medical research. As of February 13th, 2023, we have over 598,000 participants who have enrolled. Over 414,000 of those participants have completed all the initial steps. So far, we have just under 81% of our participants who have been underrepresented in biomedical research, including clinical trials. Next slide, please. Stigma is definitely a something I've always been interested in terms of it being a barrier to receiving care, becoming more knowledgeable about issues that affect us, and why I joined as a researcher ambassador, the All of Us research program, is its approach. It's a very intentional approach to speaking with the community. It is working to earn the trust of communities previously disenfranchised by medical research, and is engaging them in a safe, protected way that can help enable a deeper understanding of disease biology, and what I think is very important, a more precise approach, an individualized approach to care. Now, historically, the diverse data needed to paint a complete picture of human health, that's the biological, environmental, behavioral, socio-demographic, that has not been easy to capture in one place. So the National Institutes of Health All of Us research program is bringing this data together on a single platform and working to ensure that it's not only secure and protected, but also made available to diverse researchers across a wide range of settings. This was especially important to me because not only do we need diversity and representation of our participants, but also our researchers. The researchers need to look like the communities that they are working with. And so this includes researchers who are from or currently living in some of the underrepresented communities that bear a disproportionate burden of disease. The data that is captured includes survey responses, physical measurements, biosamples, data from electronic medical record systems, and data from wearables like Fitbit. And there's more genomic data forthcoming. All of this data voluntarily provided by participants. The All of Us data set follows participants as they move, age, develop relationships, get sick, and try treatments. It is now available to researchers with ERA Commons accounts through NIH and institutional sign-off across a wide range of settings. Next slide, please. So this website, launched in 2020, is one of the main points of entry for researchers. Now, anyone can search existing research projects, especially our participants. Again, transparency and visibility was key. And on this page, people can also look at aggregate data and any other public-facing overviews of participant characteristics and data types. No individual or identifying data is available. Then researchers, if they want to get more involved, they can register to access in-depth data and the tools within the researcher workbench. The numbers here are from January 8th, 2023, but you can see the different data points that are collected, drug exposures, lab measurements, procedures, observations, and things like that. There are three tiers, three levels in terms of the data. The public tier data is available to anyone at the researchallofus.org website. Users can explore aggregate overviews and interactive data previews with all of the identifiers removed through this data browser. The next level is the registered tier data, which is available to researchers with an institutional sign-off, and they have login.gov credentials. The privacy and security safeguards are in place, such as the removal of participants' direct identifiers. All of that has been applied to the data at this level, which protects participant privacy. Now, a third level of access is the controlled tier data, which is available to registered researchers and users who have amended institutional agreements. They've completed a thorough responsible conduct of research training. And at this level, it includes expanded demographics, genomic data derived from WGS and array genotyping studies, COVID-19 data, electronic medical records data, and more. Researchers can explore publicly available overviews of genomic data in the data browser. And the researcher workbench, it's currently supported by R, Python, and other widely used open source platforms for statistical analysis and data science. The tools and the resources for researchers include workspaces, notebooks, a data set builder, cohort builders, and user support hubs. Currently, we have 484 registered institutions. A little over 3,600 workspaces have been created, and there are over 4,000 registered researchers. Next slide, please. We can gain new insights about populations or subgroups of people, like people with HIV or people at risk of HIV, through the connection of biological and social determinants of health data. The social determinants of health data include information about people's neighborhoods, their social support, their discrimination experiences, food security, all of the things that are really important when you think of the care continuum in terms of HIV. Next slide, please. Go ahead. This was the social determinants data. You can go on to the next slide. So what I wanted to talk to you a little bit now, after giving you an overview of the AOU research program, what I'm interested in and what I'm doing in terms of as a researcher using the AOU data. People with HIV are living longer due to the development of antiretroviral therapies, but the research suggests, and clinicians tell us, many people are experiencing an earlier onset of comorbidities. Some of that includes hypertension, diabetes, some mental health conditions. The research suggests that depression is one of the most common comorbidities in people with HIV, and it can affect treatment adherence and overall quality of life. So I wanted to see if the research findings were true for a cohort of all of us participants living with HIV or with HIV. Broadly, my research looks at multimorbidity patterns and behavioral health strengths and needs in people with HIV. We get a lot of this information from the surveys that participants answer, questions about their perceived general health, quality of life, mental health. And as opposed to comorbidity, multimorbidity is a more helpful way to review and assess patients with multiple chronic comorbidities, because its focus is really on the patient as a whole. And this aligns with patient-centered care. The patient's experiences, priorities, as well as their overall treatment burden are the primary focus, with no condition being prioritized over the other. And from the All of Us research insights, we can identify improved ways to implement integrated behavioral health care and identify people with needs and link them in a more timely manner. With a large enough sample size, we might be able to generalize some of the findings or gain insights into how we should inquire about psychosocial factors beyond medical issues that impact outcomes. Next slide. So for example, the cohort that I'm looking at is 4,631 individuals. Most of the participants in this cohort that I am studying are in the age bracket of 45 to 64. With 19% identifying as Hispanic or Latino. Next slide. These are the demographics of the participants that I'm currently studying. The majority of this cohort reporting a Black or African-American race. Next slide. Other demographic data that is collected or asked include gender as well as sex at birth. Participants are able to self-identify their gender. This allows us to get a more comprehensive and complete picture of the individuals. Next slide, thank you. These are the top 10 conditions in my participants in the cohort that I'm looking at, which represents what is found in the literature, the research literature. Essential hypertension, hyperlipidemia, but also note depressive disorders or major depression. A single episode was identified in 33% of the participants that I'm interested in. 685% individuals in that cohort are being treated or were diagnosed with recurrent major depression or a depressive disorder. There are different levels of severity that are indicated, from moderate, severe, and mild. Next slide. What I'm also able to do with the program is do a little deep dive into the participants. So in this slide, I have it here to kind of indicate how we gain some insights into the participants. So for example, some of our participants have been diagnosed and treated for PTSD, which we know can significantly impact quality of life and health outcomes and treatment. We can identify which of those participants were connected to services like therapy and for how long they were utilizing that service, as well as other conditions over time and the top procedures over time. Next slide. Now, I was interested in how participants perceived their overall health, their mental health, their social support. And these are the numbers from the overall health cohort. Overall, people participating in the AOU research program report good or fair health. What I want to be able to do eventually is compare groups with HIV and Hep C comorbidity on treatment versus those who are not on treatment for Hep C. So you're able to get some of the information about medications, treatment initiation versus diagnosis date, and maybe understand were there particular factors that resulted in a delay in treatment onset. Next slide. For my participants, I noticed that majority of them reported their overall mental health as good or fair, as opposed to what we would like them to be at is very good or excellent. And of particular note, 5.4% described their overall mental health as poor. And so what the data set would allow us to do is look into some of the factors that might be contributing to this so that we can better identify ways to intervene and improve mental health in people with HIV. Next slide. Compared to all of the AOU participants, we have 17.9% of the 10,000 participants who responded with fair or poor. So obviously this would warrant some additional statistical analysis to do a test of significance and the difference between the two groups. But from a quick glance, you can get a sense that people with HIV are reporting their mental health to be less well compared to the overall cohort. Next slide. If you're interested in joining us and registering as a researcher, You can collaborate with others within or even outside of your institution, which is one of the benefits of joining the AAU program. On the All of Us website, you can learn more about the AAU program. You can identify if your institution has an agreement. You can register. Once you're registered, you're able to verify your identity and complete the training and code of conduct and research. And then you'd sign a data user code of conduct agreement, and then you'll be able to access and create a workbench of your own and do studies and work that's important to you. And that is all I have. Thank you.
Thank you, Dr. Julia Garcia Diaz, for your presentation too. Thank you to Dr. Josh Matacotta for your presentation. Now we are in the session of questions and answers, the Q&A. Please, any person who had a question, put it in the chat and we will get it to our speakers. Okay, I have one question here. This is for Dr. Garcia. The Hispanic community faces significant barriers to accessing HIV care. What healthcare initiatives can we implement in Hispanic communities for women and adolescent girls seeking HIV services? Dr. Garcia?
I think that's probably, you know, a big question to answer, and I can tell you some of the things that we have done here in the city, and we have groups which is called FACES, and it addresses women, and we didn't even start about talking about pregnant HIV women in terms of the care. So there's one specific it tries to address. Because then you have the babies and you have all of those. So it's not just addressing mom and addressing just women in general. So there are groups that are specifically created to address those populations. And the people who are providing the care, again, they have to be bilingual. They have to go where the patients are and to be able to go to the areas. And I think that that's probably the biggest challenge is to be able to have enough people who sort of are have the ability to communicate, but are able to bring that to the communities themselves rather than to wait for them to come to us. Diagnosis and testing. There are also several programs that sort of go to the settings. You can have a van, you can have anything, but you can go and have things at the churches or areas where Hispanics are, and to be able to increase the testing. And it's not only good to just have the testing, how do you link them to care? So you have to have a plan. If somebody's HIV positive, what are you going to do? How are you going to link them to care? What are the resources? So, I mean, there's the between treatment, prevention, and testing. I mean, it's a huge question. And I think that how do we address them all? We can't just do one without having a complete, that's me.
Yes. And in the chat is another question. There's do participants has to have insurance to join the program? Dr. Garcia. Dr. Garcia?
Join.
Yeah, to join the program, they need to have insurance, health insurance?
No, they don't. It depends on sort of where we're talking about, but no, most of the program that I mentioned does not have to have insurance. So they sort of link into resources in the community.
You know, it's so wonderful. The participation of diversity in medical research is very important, but so is that diversity in health condition is so important too. I had another question. This is for Dr. Matacotta. Is to apply or be approved as a researcher, on the workbench and access the registry and control type. They say what I need to become to be a researcher.
Yeah, absolutely. First, you want to check to see if your institution, wherever you're at, your university, your hospital, has a institutional agreement, and if so, you're able to register, sign up, and to be an approved researcher on the workbench and access the registered and controlled tiers. More information is available on, I believe it's in the chat, but researchallofus.org, sign up, and there's information there for you to see how you can become apply and become an approved researcher.
Victor, this question also is for you, Dr. Matacotta. They say the total percentage of Hispanics or Latinos individuals part of the all of HIV research is significantly lower than not Hispanics or Latinos. The question is, what are ways to help increase these numbers?
Yeah, it's a very good question. And I think that is the main goal and mission of this program. The relationships with the community is critical and important. And so there are a number of community engagement partners who are spreading the word, providing information to participants, answering questions, actually spending time with them to answer any of their questions, and also providing this literature in the Spanish language. It is definitely, it makes sense that a lot of people may be concerned about being further stigmatized with, through their participation. And that is one of the key things with researchers who undergo training before getting into the data set, is they learn about the ethical use of the research data and the importance of not further stigmatizing people with potentially stigmatizing conditions. It really comes down to partnerships. And what is great about the NIH All of Us research program is there are participants who serve as an advisory capacity, and they're always aware of what is going on with the program and what kinds of research are being conducted.
Yes, being a part of the All of Us research program as a CPGI, we are in the education and inform the community to know about research. And you were mentioning that one of the biggest things for researchers and for this project of research is in engagement community. That is the best, and have the trust to go and really invite the Hispanics to be part of this program. Dr. Garcia, there are various preventive measures available for women who are more likely to be affected by HIV. However, they are often underutilized. The question is, why do you think this is happening, and what can we do to increase the utilization of preventive measures for HIV?
You're talking about sort of the prescription, the medications for prevention. You're talking about PrEP.
Yes.
Yeah. And so there are ways to sort of acquire, and there are programs, and so that there have been in different states are certainly different. But I think the first hurdle is to sort of be able to offer it, to write the prescription. So a lot of they're not even offered. We looked at our emergency room who was trying to sort of increase our HIV testing, and when we looked at everybody who sort of came through, only 18% of those who came in for STDs and syphilis, they were doing RPR, but they weren't doing HIV testing. 18% of those, I mean, that's just dismal, 18% got an HIV test. and then they don't get offers. So if we saw those numbers of 10% and 14% of actually being offered PrEP. And so you have to be able to offer and then see some of the programs that are there to sort of that they may be able to access. And then not just one prescription, but how do you stay in care? So when you look at the prescriptions over a 1 year period, only about 30 to 40% of those who had the prescription had filled it. Of course, the step that is missing is your question. Did they not fill it because of lack of resources? Is it because they just didn't want to have that pill? And so there is a great deal to do, but I think the number one is we need to be able to test, and those who are at risk offer it.
Thank you. Thank you. Thank you again for your expertise and sharing with the public and all of us this important topic, and as well our audience for participating today. We thank you, every one of you. The recording of today's discussion will be added on the NHMA YouTube page within a week. We hope that everyone enjoy our robust conversation. Please join us for our upcoming events that we are in the screen. And again, thank you very much to our guest speakers. Thank you, Dr. Garcia and Dr. Matacotta.
Thank you.
Thank you.